of the webinar Philosophy of Psychiatry. So I'm Sarah Arnaud, a postdoc in philosophy at the University of Antwerp in Belgium, and I'm co-organizing this webinar with my colleague Anne-Marie Gagné-Julien, who is a postdoc at McGill University in Montreal. So we started this webinar during the pandemic where everything was online, and we realized how useful it was to be able to welcome researchers and people interested in the field from all over the world around some specific discussions. So thanks to all the speakers who gave their time and came to share their expertise. Thanks also to the attendance that we had. We can say that this first edition was very successful, and that is why we decided to keep going online. So we are thinking of organizing maybe things in presential in the future, but we hope to also keep the webinar rolling as long as people are interested. And for this, we want to thank Amandine Catala, who is professor at UQAM, University du Québec à Montréal, and owner of the Canada Research Chair on Epistemic Injustice and Agency, because she has been our main support in the process through the sponsoring of the chair and also personally. We also want to thank the Department of Philosophy at Université du Québec à Montréal, as well as Anne Brel-Cloutier, who is a philosopher who takes care of our websites and your registration process, as well as Benoît Rouillet for sharing his artwork, which is about mental health for the graphic design of the website. So the sessions will last an hour and a half with 45 minutes of talk and 45 minutes for discussion. And they generally take place at noon Eastern time, except for the one today. So we invite you to keep spreading the word so the sessions can remain active and popular. And today, for the first of this fall, we have the pleasure to open the semester with Lisa Bortolotti. Lisa Bortolotti is a professor of philosophy at the University of Birmingham. She's a philosopher of the cognitive sciences, focusing on the philosophy of psychology and psychiatry. She's also interested in biomedical ethics. She's the author of Introduction to the Philosophy of Science, Delusions and Other Irrational Beliefs, which was awarded by the APA Book Prize in 2009. And last year, The Epistemic Innocence of Irrational Beliefs was published. She's also the editor of several volumes, Philosophy and Happiness with Matthew Broome, Psychiatry as Cognitive Neuroscience, Philosophical Perspectives, which was listed among the Guardian Books of the Year in 2009, and Delusions in Context, published in 2018. Today, she will talk about the Agential Stance, how to support young people in mental health clinical encounters. So Lisa, if you want to share your screen.
Thank you, Sarah and Anne-Marie, for the invitation and for the very generous introduction. And thanks everybody for being here at an unusual time. It's kind of much better logistically for me. So the talk I'm going to present today, if the technology helps me, is a part of a project that I'm running together with a team of interdisciplinary researchers. Can I just check that the slide shows okay? Is that fine? Okay, good. And the PI, so the person in charge of the project, is Rose McCabe at City University London. And as I will show you, it's an interesting team. It's the first time that I'm part of a team that is so diverse. The project is funded by the Medical Research Council, and the focus is agency in youth mental health. So our initial intuition, the reason why we came together as a team, was that in some clinical encounters, it is particularly difficult for young people who are in a crisis to preserve their sense of agency because of certain behaviors that clinicians and practitioners were having, maybe inadvertently. And so we thought about ways in which we could improve practice and inform future training of practitioners. What the group had available, thanks to a previous project, were clips of real-life interactions that were being transcribed and analyzed through conversation analysis. So what we did as a team of researchers was to sit together, actually meet together on Zoom, it turns out, and watch these videos together and share what we thought about it. The interesting thing about this project is there are two groups of researchers which met separately and only sometimes together. The first group is a group of young people with experience of mental health services coordinated by the charity MacPin. And the second group is us, basically philosophers, psychologists, sociologists, and psychiatrists. The common aim is to learn what undermines and supports the sense of agency in real life encounter that have been video recorded. And I'll show you now who we are. So this is the academic team. We've got experts in clinical communication, in psychology, in public involvement in research, and of course, psychiatry, philosophy, and ethics. The method that we use is something that is often adopted in sociology, conversation analysis. So we've got sociologists as well as part of the team. And then we've got the MacPin Foundation with the Young Person Advisory Group. On our website, there is a nice audio clip where one of them explains why she was interested in the project. They also wrote some blog posts on imperfect cognition about their experience as part of the project and why they think agency is important. In a public engagement activity that we did together with schools in the London area, they also devised some posters, you see here as an example, about what they wish their younger selves had known about mental health when they first encountered problems. And this was supposed to be some kind of help to young people who are now finding themselves struggling with their mental health, and they might not know where to go or what to think. And so advice from people who are still young, are still struggling with their mental health, may be more relevant than advice from other types of experts. So that's the team, and that's the purpose of the project. As I mentioned, what we do is observe video recorded interactions. Sometimes these interactions are really long. Sometimes we just see little clips of them. We comment on what is happening. And what is really interesting about conversation analysis is that we're not focusing just on the words that are being said and their content, something that we could get very well from the transcript alone. But we focus on all other dimensions of the conversation. So how people react to each other, how they move in the space, with gestures they use, where they look, whether they look down, whether they look at the person, whether they, where their gaze goes. What about the tone of voice as well? I mean, is it engaged? Is it distracted? What is happening? And as you see from the little sample of the analysis, everything is recorded, everything matters. Whether the voice is creaky, whether there is a laughter, whether there is a pause, how long the pause is, and so on. And basically, it's a way of examining everyday discourse to understand how people manage their interactions. And I think it's particularly useful when the interaction is between people who have a power relation. So where one person is clearly dominant and the other person is clearly subordinate, because maybe the dominant person has expertise that the subordinate person doesn't think they have, or they can impart advice, or are being consulted on something. So this is what we do. And what I'm going to present to you today is our take on this journey that we have done together in terms of the steps that clinicians and practitioners may want to take to ensure that they do not inadvertently undermine the sense of agency that people come with, and actually in some situations support their sense of agency. So we found 5 themes that resonated with us and resonated with the group of young people on the project. It's very important to say that we didn't just come up with these 5 things and then try to find them in the transcripts or in the videos. We really started from the videos, and then we discussed how to best phrase and describe the things that we thought were important. And sometimes that was a very long process of revision. I will give you an illustration of one of these processes. But our sense is that a practitioner's agential stance towards the user, so a practitioner way of taking the user to be an agent, someone with agency, involves validating the experience of the user, legitimizing the user's choice to seek help in that particular circumstance, avoid objectifying the user, affirm the user's capacity to contribute to positive change in the past and in the future, and involve the user in decision making. I will go through each of these in the presentation. I just want to make some preliminary clarification. So I don't have any particular preference about the terminology. Here I'm using the word user, simply because in the transcript, I will use P for practitioner. So I just wanted a different letter. So I'm not using patient because that would make 2P to make the transcripts clear. And also users seem to be something that the young people were happy with. But here we're talking about really young people seeking help, maybe people who attempted suicide, or people who had suicidal thoughts, or people who were experiencing other types of problem like eating disorder. So some of these dialogues or interactions may result a bit upsetting for some of you. So I'm just warning that these topics will come up in the description of the interactions. Obviously, there is a power imbalance.
Vas-y, tu me parles. J'écoute un cours, c'est pas grave.
Sorry about that.
That's no problem. So I just wanted to say something about those 5 themes that we identified. We think that actually the agential stance is something that may have wider application than just the mental health context. It can actually apply to other relationships that are characterized by a power imbalance. An example could be parent and child, or it could be teacher and student. So where there is a sense in which the dominant party maybe has a knowledge or expertise that the other person doesn't have or doesn't have yet, or whether the dominant person has the capacity to help or advise the subordinate party. So it looks as if in all of these interactions, there is the potential for the dominant party to undermine the agency of the subordinate party. And it looks as if those 5 things may help the dominant party not to do that. So I think that actually the agential stance might have wider applications than the one that we identified in the project. Okay, so let's just get started with the first one, validating the user's experience. In general terms, this is about recognizing that a person's feelings and views are worthwhile. They matter, they are important. It doesn't necessarily mean that we should share those views or should agree that things are exactly as the person describes them, but take them seriously. In the clinical setting, it involves the practitioner taking time to understand the user's experience without immediately dismissing it or assessing it. That was something that for the young people was very important. The sense that sometimes they were talking about what they felt was important for them, but immediately what they were saying was being categorized or evaluated. There was no attempt to try and understand their experience better. So what happens in the exchange? There is a conversation So for the practitioner, communicating validation in this particular setting involves listening in an attentive way and acknowledging the user's experiences, maybe also asking some probing questions to know more, to understand better. The validation involves exploring why the experience is problematic for the user, why there is a problem, and establishing how the problem feels to the user. So it's not immediately finding a solution, it's rather seeing why what is being presented is of concern. So I'm just going to give you first an example of something where validation is present, at least we felt that it was there, and that's the green one. And then I'm going to give you an example where validation was not being offered, and that's the red one. So in this particular exchange, you see the user distressed, crying, and talking to the practitioner, saying they died in a car crash, and the practitioner says, yeah, and nods. So when I think about that, it just fucks me up, and the practitioner nods. Of course, it's a really horrendous event to have happened, isn't it? And the user immediately says more about the event and about the way they feel about it. Obviously, the other things are my ex that I had my first child with. I'm supposedly abused her basically, and I heard it's being in town where I live. So shares more. So this is something that we see over and over again. This is of course just an example. The young person shares something upsetting. When the practitioner recognizes that the experience is upsetting, and here it's very minimal participation by the practitioner. They just say it's a really horrendous event to have happened, isn't it? But that's enough, right, for the young person to feel that they can continue and share more. And this is a pattern that we see over and over again. The young person shares more if it has some validation of their experience. Compare it with this other exchange where the young person starts saying, I feel very unsafe in myself. Practitioner says, right. And I'm constantly having these horrible thoughts, and I'm in a lot of distress, and there's nowhere for it to go. And right, okay. And here the young person cries, I can't go on any longer like this. I just want to be sedated. I just wake up and for it to all go away. Practitioner, unfortunately, that doesn't happen, does it? No. Here, the young person, again, is distressed. All right, then, can we get you a glass of water or anything? So you see here, there is no acknowledgement that the experience is upsetting for the young person on behalf of the practitioner. There is the minimal engagement that you get from nodding or saying right. And of course, here we're all missing, because we don't have the videos, the other type of evidence that we get from the gestures, from the gaze, from the way, for instance, the practitioner leans towards the young person or so on. But the engagement here is basically minimal. The practitioner doesn't say anything more than they could say in order for just kind of avoid stopping talking altogether or stopping the conversation altogether. And you see that this seems to increase the distress, or at least doesn't stop the distress, but there is very, very little engagement, very little interest in exploring what is it that the young person finds distressing. On the other side of these bubbles, we've got the purple ones, and these are comments that the Young People's Advisory Group offered when watching videos showing absence of validation. So this is one comment that they made. By kind of bypassing those feelings, it's kind of like almost implicitly telling the person, okay, your feelings are a problem. I'm uncomfortable with your feelings. We're not going to talk about them. We're just going to fix them. So that was, according to the young people's advisory group, the kind of message that a practitioner who is not validating is offering. And again, there is no, oh, that must be really bad for you. We saw that there was that in one of the transcripts, but not in the other. It's always, we need a solution to this problem right now. And I think that's where it all seems to go wrong. So there is this sense that the person is thought to be a problem and not more complex than that. And the experience is not thought to be important, at least not the details of the experience, of how the experience feels to the person. Very close to validation, but I think a step up from validation is the sense that the practitioner can legitimize or fail to legitimize the user's choice to seek help in this situation. So remember that these are cases where people find themselves in distress. This is a crisis team and are sent to an equivalent of accident emergency for mental health. So here, what we mean by legitimizing the user's choice to seek help is recognizing that the person's concerns deserve attention, deserve to be taken at face value, and they are important and they need to be addressed. In the clinical setting, this involves the practitioner confirming that the user is justified in seeking help from the team. And unfortunately, we see very little legitimization in these exchanges. So while validation involves communicating that the user's experience matters and maybe wanting to understand more about the user's experience, legitimization involves communicating that the user is in the right place and made the right choice in seeking help. We saw there is absolutely very little of this in these exchanges. Indeed, very often the young person is challenged by the team. Why are you coming here? Do you think that it's bad enough to justify coming here? Wasn't it a mistake that you are here? And you find that a lot, unfortunately. So we see, why don't we see the good example first? Okay, and it's just about trying to get more to you did exactly the right thing today. Here the young person nods, exactly the right thing. So if you get to that point again, you do exactly the same thing again. And there is a big nod. So here the practitioner is praising the young person for seeking help. He's telling them you did the right thing to come here today. And if it happens again, please seek help again, come back here. Completely different in this case. This is a young person who is a student, and they first contacted the university support services. And according to the support services, the situation was very serious and they had to go to the crisis team immediately. The practitioner challenges that decision. So they say, so you had that talk with the crisis team outline, and then you have come up to here. Did you discuss that with them before you came up? Or no, I rang 111 first, and they said, if you ring the student health center, they'll do an emergency telephone thing. Then they said ring crisis team, and if not, go to A&E. That's accident emergency. And the practitioner, so what did you want them to do, Anne? So I guess this is what I'm struggling a little bit to get. What did you think they could do? So here there is almost a challenge to the young person. Why have you come here? There is a failure of recognizing that the young person's concern is legitimate and deserves attention. And unfortunately, we've seen quite a bit of this, especially this going back and forth between crisis team and student support from the university. Like, you should go to them, and the student support says, no, you should go to them. So it's a terrible situation for someone who is unwell. Okay, so what did our young people's advisory board said about these cases? When you're really struggling with mental illness, there can be this really big overwhelming fear that your thoughts aren't real, or that you're kind of over dramatizing things, or you're being oversensitive or overreacting. To go to a mental health practitioner and have them say, oh, you seem pretty fine, I feel that that experience can almost amplify the negative self-talk, like, see, it's all in your head, or you are the problem, or you're the only one who thinks there is a problem. It's not true. Why do you think you're so special? All of those things. So here what they're saying is that already lots of things are going in the head of a young person who feels unwell to that extent. Already the young person is doubting themselves about what is it that is going on. And having their worst fears and doubts confirmed in that way by a practitioner when they found the courage to seek help can be really bad. And again, similar idea here. All of your friends are like, why didn't you say anything? But if you've had a medical professional tell you that your thoughts are fine to just exist there, then you then think, well, maybe it's really serious. Maybe I do need to tell someone to help me. And you then want to go and seek the help again because of what happened previously. But we found this extremely interesting. So the idea is that if you have an experience where you seek help and your need for help is dismissed, is actually challenged almost forensically by the practitioner, what is likely to happen in the future is that you find yourself in a crisis, but you don't seek help anymore because you don't think you'll be taken seriously. So this is potentially, I think, a dangerous way for practitioners to interact with young people who are in distress. Further on, what we focused on, and again, we discussed how to best phrase this. In the end, we went for avoiding objectifying the user, but I will explain what we mean by that. When we treat someone as a person, when we treat someone as an agent, we treat them as something complex. You know, they're not just like one thing. They can have different beliefs and desires and intentions, and these beliefs and desires and intention can be also kind of conflicting with one another. A person is a complex thing. But very often in the clinical encounter, what we were observing is that the young person is thought to be one thing. You know, it's got to be one problem of a certain type, put in a box and labeled. So what we wanted practitioners to avoid here is degrading a person to the status of a mere object and treating them instead as agents with multiple goals and interests. And of course, this fits very well with validation and legitimization. In the clinical context, it involves not seeing a person just as a type of patient or as a problem to solve, but acknowledging their complex mental lives and needs. So what does this mean in a conversational exchange? The practitioner may objectify a user by telling them that they need to attend talking therapy, for instance, because that's what works for depression, without actually thinking about the particular needs or experiences that feel important to the user. So it may be that the user tried talking therapy in the past and didn't work for them, right? But this doesn't seem to be a concern of the practitioner. What they want is a solution that is quick and seems to fit what they understand about the user. But the user is not thought to be, again, a complex person with intentions and preferences, but just something that needs attention in a kind of very almost automatic by default way. An objectification can be a consequence of lack of validation. So if you haven't taken time to understand the person's experience and what is it that they feel is a problem, why they sought help in the first place, then it may be easier to fall into objectification later in the encounter, because the full range of experiences of the young person has not been considered at all, has not been accepted. So here is an example that I think is very interesting. We looked at this clip a number of times. So this is a young person who has been referred again by university support services because of suicidal thoughts. But you will notice in this transcript, very similar to the previous one that we saw, that the practitioner almost challenges the idea that the person is really suicidal. So what kind of plans would you have had tonight, young person? I got a few events on because I'm part of rugby, skiing, tennis, and they all have different events on tonight, like every Monday. I see. So we could safely say you are not going to end your life, do something that would have not tonight. Yeah. I wouldn't have ended it tonight. No. Okay. So maybe there was a bit of miscommunication because they brought you here because they were saying that you were suicidal, and no, I am. But like I feel I can. I mean, I haven't done it yet. So this is a really interesting exchange, I think, because you can see the reaction of the young person to the questioning. The practitioner is trying to prove that the person wasn't really serious about ending their lives because they had plans, right? As if, you know, the fact that someone does something routinely on a Monday, maybe a reason to doubt that they had certain types of thoughts if they say that they had them. And what you can see is that gradually the young person starts doubting themselves and affirming less and less strongly what they feel, their thoughts were. And again, you can see this again and again. So if the practitioner starts probing the young person and re-describing their experiences in a different way that they initially do not recognize as the experiences they had, eventually the young person just stops providing their own account. This could be for a number of reasons, because they don't feel it's worth talking to this practitioner and saying anything more because they've lost the trust. They feel that it won't make any difference. Or it may be that the person themselves are kind of really trying to think about their experiences in a different way, in the way that is being suggested by the practitioner. And that may be, of course, a difference that depends on the individual and the situation. But you can see, that the fact that the person had plans seems to be immediately a reason to think that they weren't thinking about ending their lives. And of course, that reduces a person which have a multiplicity of interests and needs and even conflicting desires to something that can be categorized either as suicidal or not suicidal. And to the young person, the feeling is that all that matters to the practitioner is be making this choice. Nothing else, right? To tick the right box. Okay, so this I think has to do also with diagnosing. So in general, diagnosing is felt to be a positive step from the perspective of young people, because they feel that they're being given a sense of what is happening to them, a potential explanation, a potential source for support. But it depends how the diagnosing is happening. And if the labeling happens too soon, without the experience of the young person being explored, that can be actually very detrimental. So we talk about labeling in many different contexts. People are labeled when they are assigned a category, but also sometimes we talk about labeling in a negative way, when people are reduced to a particular part of their identity, right? When you're treated just as a woman, or just as a philosopher, or just as an Italian person, and so on. And the complexity of your life is lost in that. So the labeling can be detrimental when it has the effect of limiting the person's opportunities for growth and action, when the person is just stereotyped into a set of characteristics that are associated with a part of their identity. So in the exchange, in the mental health care context, practitioners may describe the user's concerns so that they neatly fit a certain diagnostic category or a certain checklist, and consider the user's concerns merely in the light of risk assessment. So we saw the example of someone who may or may not be described as suicidal. Ultimately, what the practitioner seems to be wanting to do is not help the young person understand what is going on, but being able to do the risk assessment correctly. Are they going to do it tonight or not? Because if they're not going to do it tonight, it's not my problem. So that's how it feels. I hope that wasn't the intention, but that's how it felt in the interaction. So this is a conversation with a good practitioner, but here the person is describing the feeling of being labeled incorrectly in the past. I've always been told that it's just anxiety and depression. What's your point? What do you think yourself? So you see here a good practitioner who asks a probing question. I don't know. I just feel like that kind of, I'm not sure, not a cop out, but I feel like they haven't, doctors that I've spoken to haven't really bothered to go deeper. They've just thought she's a young person, I'm going to look at these symptoms, ignore the rest, and just fit it to what I want it to be. I see. So I feel like I haven't ever had the right treatment really, but I don't know why. I just don't feel like I have. So here the person describes an act of labeling as we were discussing earlier. And here from the Young People's Advisory Board, what did they say about these cases? Life is hard, and instead of them dealing with it in a more holistic way, they've just been put into this box. This is what I have when you're given a diagnosis. So this is what I have. It's like a simple explanation for something that has many complexities. And I feel like that's the thing about seeking medical attention, is that they just give you a name, right? So depression or anxiety or eating disorder, you end up being that label. The rest loses interest. At least the practitioner doesn't seem to be interested in it. Okay, so we got to the really tricky one. I was suggesting earlier that for some of these themes that we identified, there was disagreement about how we should describe them, or we weren't sure ourselves. So initially we thought, look, if we're talking about a person being an agent or feeling like an agent, surely one of the most important things is feeling responsible, right? We feel that someone is an agent when he makes choices, when he acts in a way that fits with their goals and aspirations. And when the agent does that, they take responsibility for that choice, they take responsibility for that action. And so initially we thought about it in terms of responsibility, and then we realized that that wasn't the right approach to take, because especially in the case of a young person whose identity is still fluctuating, is still unstable, is still being developed, and a young person experiencing mental health struggles in particular, the idea of responsibility can be interpreted as a burden. And from the perspective of the practitioner, can be a very easy excuse to blame the young person for what is happening, either epistemically or morally, as we will see. So we decided that we need something slightly different from responsibility, but that gives us the same sense of the person being capable of agency. And we thought that what the practitioner could do is affirming the user's capacity to contribute to positive change, the capacity that they have had in the past to do it, and the capacity that they have in the future to do it. So what does that mean in the exchange? So building agency is about not just validating experience and avoiding objectification, but thinking that actually the young person can be capable of positive change, can initiate something that can help them get out of the crisis in which they are. But it's important the practitioner does not use the language of moral or epistemic blame, because in many of these situations, the young person already tends to ascribe to themselves a lot of responsibility for instance, causing suffering in other people, or having not the life that they would like to have. And if the practitioner actually confirms that kind of impression, the negative thoughts can actually increase and become worse. We have seen, unfortunately, in many interactions, the practitioner putting epistemic and moral blame on the young person. I'll give you some examples. What do I mean by epistemic blame? Well, an example would be the practitioner indicates that the young person should have considered the medical risks of self-harm, or should have known what dosage of medication they needed. So the crisis in which they are is basically their fault. Didn't you know that you had to take this, and so on? Moral blame, I think, is even more upsetting, especially when you read the transcripts or see the videos. That's when practitioners suggest that the young person should have considered the negative impact of, for instance, their attempting suicide on their family. And this is especially bad. One of the young people's, one of the members of the Young People's Advisory Board made us notice that, because the implicit suggestion here is that other people's interests are more important than the young person, even at the time when the young person is in crisis, clearly, and that is not the right message to give. So let me start with a positive example. So here is a practitioner almost praising the young person for having done really well in the past year. It's really hard to change things when you've got coping strategies or whatever. It's really hard to change it, and you've done really well to change. I saw you last year. I saw you a few times last year. Yes. When you talk about your bad times, that's how I remember you. That's how I met you, and things are completely different for you now. Yeah, I'm doing better. So here there is a recognition that the young person managed to do something to improve the situation. But what you find that is really important in these cases is that the practitioner always recognizes that the person did it with the right support. And I think that helps with blame in case things don't go well. So it's not, I mean, it can be too demanding to expect a person who is struggling with their mental health to make positive change all by themselves, because very often it is the environment in which they are. For these young people, very often it's their family situation that creates a number of problems for them. So the idea is that, yes, you have made a change, you have given the right support, and you've been able to make positive change. So the idea is that they're not on their own. And this is important because if in the future this person doesn't manage to keep up the good practices and habits that they have learned to implement in their lives to improve the situation, they don't feel like they've let themselves down. They know that maybe the problem could be missing support. And that's why I think affirming the user's capacity to contribute change, given the right support, is a much better label than responsibility, even if it is a mouthful indeed. What about the negative aspects? Okay, so you need a little bit of background here. This was a person who was brought in after having an overdose. So they wanted to end their life. And apparently they did it in the house at the time when their sister was there. And here what the practitioner is saying is you, in the long exchange is like, you know, why did you do that when your sister was there? Didn't you realize that you'd have been really upsetting for her to find you? And the young person is very distressed by this and keeps saying, I really care about my sister. I wouldn't want her to find me. I thought someone else would have found me, and so on. But here there is this really attempt to put some kind of moral blame on the person for attempting to end their lives. So when you say you are concerned about the impact on other people, well, had you thought about how would happen for the people that found you? I didn't want it to be my sister. Okay, but you said she was in the house at the time, so it could have been her. And here the young person concedes, yes, it could have been her. Yeah, and long silence. And I think, again, you find this almost forensic style of asking questions, you know, it's like, oh, you say you didn't want to hurt other people, but you knew that your sister was there and you still did it. So clearly, you know, almost like trying to find the contradiction in what the young person is saying, which is a terrible thing to do for someone who just had the night that this person had. And also, you know, it doesn't seem to improve, like it doesn't seem to have any positive impact on the person's well-being. So let me say a little bit more about the philosophical literature on this. So attributions of responsibility and praise and blame often go together. There have been suggestions, of course, especially in the mental health context, that responsibility could go without blame. And an example, for instance, is Anna Pickard's work on personality disorders and other conditions. And the clinical context, she says, there is a conundrum. In a way, you have to take the person to have responsibility, otherwise they cannot really participate actively in their treatment. On the other hand, you cannot blame them because it is proven that blame actually impairs the therapeutic relationship, but also doesn't help the person get better. So how can you consider them responsible without blaming them? And she comes up with this amazing framework of responsibility without blame. So this is an example of what she says about the conundrum. How is it possible to hold service users responsible for behavior that causes harm and suffering to the self and especially to others without blaming them for it? Encouraging responsibility is central to effective treatment. Blame, in contrast, is highly detrimental. Some people do not entirely agree with Anna Pickard. They say that some form of blame can be beneficial, some form of nurturing reproach. And for instance, Janet Kennett comments on Stribus and Brandenburg, a nurturing stance. She says the nurturing stance begins from the assumption that the person is not yet fully responsible, but can be supported to become so. The responsibility of the service users is thus primarily forward-looking, not backward-looking. So here they say maybe some kind of approach may be appropriate. We have preferred to talk about the affirmation of users' capacity to contribute to change. And one comment that the Young People's Advisory Board made is that we should really think of it in terms of scaffolding, like you're building your agency. So they said practitioners should acknowledge that the young person's current state of distress is not their fault or a direct result of their actions. But they should also encourage the young person and note that they have the inner strength and capacity to eventually redirect and change their current circumstances, almost like a scaffolding approach. And again, as long as the attribution of this capacity doesn't translate into the claim that they don't need support. Okay, we got to the last step of our agential stance, and that's involving the user in the decision-making process. So that's about enabling the person to participate in decisions about their treatment, for instance, recognizing that they have some relevant knowledge to share. In the clinical setting, this involves the practitioner treating the user as a partner, as an informant, whose experiences, views, and preferences make a difference. I can give you an example of a positive one on the subject of your mom. Have you ever had any counseling, any grief counseling? No. Counseling for the loss of a family member? No. What do you think about that? You see, the practitioner asks the young person what they think about this option, and the young person opens up. It's just talking about it. I don't want to keep doing it, but it upsets me. I don't want to feel upset. I don't want to talk about their mom. And then they go on to discuss other options. So the practitioner takes on board the young person's reply. Completely different here. Do you want to try and address your mood? What do you mean? Do you want it to be different from what it is? Yeah. Yeah. Silence. So what do you need to start doing? Silence. Taking tablets? Yeah. Because what dose did you say you thought it was? Silence. 20 milligrams? 20. You need to give it a go, Jack. You see, completely different. Here, it's all coming from above. The practitioner is telling the person that they need to take their medication, how much they need to take it. And also there is a very patronizing, you need to give it a go, Jack. There is no question, do you think it's the right thing for you? Is it working for you? Nothing of that sort. So what does that mean for the exchange? In the mental health context, the user may be asked to help the practitioner identify what support the user needs in order to achieve positive change. And involving the user in the decision-making process is not an option, of course, if the user is objectified or not regarded as able to affect change. So again, I think this step comes after the previous steps that we looked at. This is the idea of the user as a partner. Both the young person and the practitioner have valuable information to bring to the table and to inform the young person's treatment. This is what the Young People's Advisory Board was saying. And also they talk about the relationship between the practitioner and the young person. If the young person and practitioner don't have an open discussion about goals and treatment and the young person's preferences, they may end up working against each other. It becomes a battle, tense interaction of who knows more, instead of what should be an active collaboration of sharing knowledge and perspectives to facilitate a young person's recovery. Isn't it amazing that our young people were saying this? It sounds really, really enlightening. Okay, so let me just summarize what I've said so far. We have built an agential ladder together. We have suggested that at a minimum, validation is what every young person that we talk to really wants from the encounter. They want to be listened to. They want their concerns to be just listened to, really, not dismissed. The next step is to think about why the young person is there seeking help and making them feel like they did the right thing, that help is something that they deserve and that they can have. The next step is to think of them not just as a problem to solve, maybe like a label or a specific diagnosis, but as someone with complexity, and that complexity is all relevant to the decisions that are going to be made about the support that they need. What would be amazing, rarely happens, but I think it will really help. It also means that the practitioner talks to the young person as someone who can contribute with support to positive change in their situation at all stages. And finally, when support is identified, there is a dialogue. There isn't just like the expert telling the non-expert what to do, but two different types of expertise, clinical expertise and experience about what is it that is not going well and why whatever experience it is not what the young person wants. Two types of expertise meeting together and a more kind of constructive dialogue happening there. Okay, thank you very much for listening.
Thank you very much, Lisa Bortolotti. Thank you, everyone. We're now gonna go to the questions.
Yes, so yeah, thank you very much for this wonderful talk. So if you have a question, just write down in the chat section that you would like to ask a question, and I will and you will be allowed to ask it. Or if you're not comfortable with asking yourself, you can write it down in the chat, and I'm going to read it for you. Yes, so first question to with Kiki.
Hi, thanks so much for a fantastic talk and so many rich concepts. I was wondering whether, I really like this idea, the part about involving the user in their own improvement or recovery. I think it was the fourth component, and the concept of responsibility that's appropriate and whether you could have responsibility without blame. And I wonder if you had thought of analogizing the relationship to that between an effective coach and someone learning a skill, whether an athletic skill or a musical skill or something like that, where, you know, mistakes are inevitable in skill acquisition, and a good coach won't blame a student for making a mistake. I think it will be very forward directed, but there's also you know, there's never doubt about the agency of the student because it's up to them to develop the skill. So I was wondering whether you find that analogy at all helpful?
No, that's super helpful. I was trying to think about other types of relationships where the agential stance can be helpful, and indeed, you know, the relationship between a coach and the kind of trainee or an athlete, for instance, is exactly a relationship where the agential stance can be applied. I'm sure there are different styles of coaching, and I'm sure some coaches prefer to have all the answers. But you're right that, you know, to some extent you have to recognize, and I think that applies to the mental health context, you have to recognize that ultimately, you know, whatever change is going to happen is going to start with the person walking towards that change, or making some kind of motion towards that change. Because even, you know, you can prescribe medication, but medication needs to be taken. You can invite people to therapy sessions, but then people need to go, right? So ultimately there needs to be some kind of involvement. The person needs to think that what they're doing is actually helping them. If they're not given the opportunity to explain what is it that they need, and they're just given from above an indication of what they should be doing, there can be disengagement and lack of trust. And I think that's what the studies suggest, that in young people meeting mental health professionals for the first time, very often, if the interaction is not positive, it does lasting damage, because the kind of bad experience that I've had translates into not wanting to seek help in the future, thinking that, you know, this person can ignore me or dismiss me, and, you know, the next person will do the same. So I think that's a really good point about skill acquisition, and something I want to think about more, and maybe bring it back to the Young People's Advisory Board if they never thought about it in those terms. But generally, I think one point that we were thinking about at the beginning of the project, and we found confirmation of it actually talking to the young people, was that undermining the sense of agency can happen in any encounter, in any encounter with mental health care professionals at any age, at any stage of an illness. But for young people, I think it's particularly like the threat to their epistemic agency and moral agency is particularly strong, because young people who seek help very often seek help because they cannot find help elsewhere in their environment, or the help that they can find is not sufficient. They are often not very well supported by family, friends, or other school, or whatever it is that characterizes their environment. And on the top of that, so that the kind of age we're looking at is kind of 15 to 24. So on top of that, their identity is forming. So they don't have a precise idea of who they are. They are kind of in the process of shaping who they are, and the environment in which they are also shapes who they are. So it is, I think, particularly difficult for them to affirm what they want or what they feel when they sit in front of a professional, someone who should have the expertise, because they're not that sure of themselves. There are lots of doubts that they have about whether, is it all in my mind, or, should I be here at all? So when the professional reinforces this kind of idea, I think it is worse than for someone in a different situation or at a different developmental stage. And it seemed to these ideas seemed to resonate with the young people we talked to. They seemed to think that when they weren't well, they were particularly unsure of themselves, and they were kind of internalizing a lot of the stigma that was around them. So thinking in terms of skills, I think, can be really beneficial. Thank you for the suggestion.
And if I may follow up, I guess I had in mind an even more literal application of the model, in that a lot of therapy involves does involve skill development, metacognitive skill development, I guess you could call it, where you learn how to react to your own thoughts and feelings in different ways, right? So it might be more than just an analogy, I guess, in some cases.
Yeah, no, that's a good point. And I guess the whole purpose of doing this is informing training for practitioners. So I think, one idea would be model the behavior that you want, like treat the person as you want the person to think of themselves, right? So if you treat them as someone who can promote positive change, they will think of themselves as capable of doing that, or at least, you're not undermining that particular feeling. And I think that applies to the capacity of acquiring a particular skill. Thank you.
Next question is from Sarah Arnaud.
Yes, thank you very much for your talk. I was wondering if in looking for the different ways of giving back some sense of agency to these young people, you also considered more specific conditions, maybe, where this sense of agency is very much at the center of what's going on. I'm thinking you quoted Hannah Pickard of some types of addictions, or even schizophrenia, or where sense of agency is thought to be, if not less there, a bit impaired, or in this contexts, is the approach different? Should it be different? How can we reconcile these, the need to give the sense of agency back with the fact that this might be the main problem for
yeah,
some people?
no, that's an excellent question. So originally we were really thinking, because Matthew and I mostly work on psychosis, so we were really thinking about conditions where the sense of agency itself is undermined. So you don't know whether it is your mind or not, you don't know whether it is your thought or not, and so on. And we thought there might be an additional reason for the sense of agency to be especially protected. As it happened in the course of this project, we had data from a crisis team that mostly sees people with mood issues. So we didn't actually watch any videos of people presenting with psychotic episodes. And indeed, what Matthew and the other clinicians in the team were telling me is that they are completely different routes. So if someone presents with something like, what could be a delusion or hallucinations, they go a completely different route. They are immediately kind of hospitalized. That is immediately considered a much more severe sort of problem. And they see different type of mental health care professionals. I think the people instead who particularly struggle with their mood, we saw someone with eating disorder, but the reason why she was there was not an eating disorder. I think for them, it's more common that you see this kind of almost gaslighting, or you shouldn't be here, you're actually fine, you'll be okay. That wouldn't happen well in the case of a psychotic episode. So you see different reactions from practitioners depending on the type of problem that poses itself. So unfortunately, we didn't watch any evidence of interactions in that context. I know that Matthew has a lot of experience with early intervention in psychosis, and he seems to say that it's a real issue. It's a very, very important issue, this lack of sense of agency for young people who experience those kind of symptoms. And I think his take from his own clinical experience, but again, we didn't watch any particular videos together as a group, is that there is a different type of risk. So instead of saying, oh, the problem is not so serious, you don't really want to kill yourself, I guess the attitude is more like, oh, your brain is not working properly, like your brain is damaged. So there is another form of objectification, if you want, where, the person feels like, the way the practitioners talk to them sometimes make them feel they're not even a person, that those things that they're experiencing are not even kind of bits of their minds, but it's just, so I think there is a problem there, again, with making the person feel that in spite of all of this, there can still be agents that can still kind of make change. So a lot of I think of the themes that we talked about would apply also to those kind of interactions. It's just that I cannot give concrete examples because I haven't actually watched videos in that context.
Yeah,
but thank you. It's a very good question. Yeah.
Next question from Christopher Nielsen.
Hi, I really enjoyed that. Thank you. I think I just appreciated that it points to that genuine and collaborative interaction with clients that a lot of us sort of recognize works and will be talked about among clinicians. At the same time, I was wondering, you mentioned this is becoming a manuscript, I think, near the start. I was wondering if in that analysis you consider the systemic and institutional pressures placed on the clinicians themselves, right? A lot of the examples you were using, because of the data set that you had, is they're in these risk assessment situations where there's so much pressure to, clinicians see their job as, I've got to keep this person alive, but more than that, I've got to keep them alive in a way that if I fail, then my practice will be considered, and it will be considered against a received view of what is best practice. And in that kind of analysis, it will be a policy-based set, did they do the right things? Did they consult with people around them? Did they, do all these things? And there is a strength to that because it keeps us rigorous, but at the same time, it seems to get in the way of going beyond that policy-based approach, or that quote unquote best practice approach, and genuinely engaging with the person, which is where your analysis is pointing. But
yeah,
I was curious about how you whether you explore that in the manuscript.
Yeah, no, absolutely. No, that's such a good point. So some of us are, I mean, not me personally, but some in the group were clinicians, and they're kind of painfully aware of the constraints. And what we found even more interesting is that in the Young People's Advisory Board, there was a lot of understanding of the constraints. So the young people recognized, that practitioners had very limited time and had to do very specific things in that time that they had with them. So actually it was their own words when they come up towards the end and saying, ultimately, if nothing else can happen, validation is enough. And sometimes validation is simply a question of the tone of voice, or looking at the person in the eyes rather than looking at your notes. It doesn't require any more minutes, or it doesn't require, anything special that you say. It's just not rolling your eyes, maybe. It's just kind of not treating me like I'm an idiot, just by kind of putting a certain type of kind of intonation in what you're saying, and so on. So it was them saying, ultimately all we need is validation. Everything else, yes, would be nice, be really nice, but it's not necessary, because the moment that you realize that the person is interested in your experience and is listening to what you have to say, that's enough for trust. That's what they were saying. So in part is that. So when we're saying, I mean, you're absolutely right. When we're saying training people, we're not kind of just saying that the whole responsibility for a failed interaction is on the practitioner. Of course, there are lots of systemic issues that need to be addressed. And the hope is that this kind of study eventually will actually escalate to address those systemic issues. And the other thing I wanted to say is that for every kind of deeply failed and upsetting, and at least for someone like me who's not used to clinical encounters, like watching these videos truly upsetting sometimes, because I could see those kids are like my students, right? So despite very problematic videos that we saw, there were so many examples of good practice. And I've tried to show you some, and there were others, where the person in the same amount of time, just with the same constraints, was able to make the person feel heard and important. So I think for us, the good examples are as important as the bad examples, because that's something that we can show in training sessions and say, it's as easy as that, and it makes a huge difference. Maybe you don't feel that it makes a huge difference, but it does. But yes, certainly we haven't done enough to address that, but it's something that we are very aware of. Thank you.
Thank you.
We have a question from the chat from Amandine Catala. So I'm going to read it out loud. Thank you so much for this fascinating talk. I was wondering how the group of young people was selected or formed for this project. I was also wondering whether MD training typically includes how to talk with patients, since communication between doctors and users seems almost as important as treatment or other types of intervention in fostering the well-being of the user and hence their agency.
Thank you. Thank you for the question. So I'll address the kind of methodological recruitment question first. So I work in a place called the Institute for Mental Health with Matthew Broom in Birmingham. And as part of that, from when we started, it's an interdisciplinary research center, but we also teach an MSc in youth mental health. We have started a young persons group. So we have our own young persons group. There are people who are paid to consult with us, help with every aspect of our research, and often our public engagement and our teaching. That said, we didn't use that group for this project. We relied on McPin, which is a charity. They have a young persons network, and the person responsible for engagement in research in McPin asked their young people who was interested in joining this project, and actually they were all women in this particular case. So 5 young women said they were interested in participating, and those were our young persons advisory group, and they were involved from the moment in which we started writing down the application. Indeed, I wanted to make you hear a little clip that they did for the funders before we got the money to do the project, where they were explaining why it was important to them. And they were involved in all aspects of the research and the dissemination. They're all authors of our papers, and they are also now producing a podcast about our results and how they feel about them that we hope can be used in training. So that's the way they were recruited. They all had experiences with mental health services, very often similar experiences to the one that we've seen with crisis teams. Okay, so the other question was about communication. Yes, so I believe that, yes, medical professionals are taught about communication. I think that's probably not enough, that more could be done. A lot has been done, for instance, by people like Rose McCabe on how you ask questions. For instance, there are ways of asking questions where the answer is just yes or no, but you're inviting the person to kind of, you know, it's much easier for the person to answer one way or the other, and especially in risk assessment, that's considered very problematic. So she's involved in training as well, based on communication and conversation analysis, but we feel that's probably not enough, given that sometimes, you know, just giving validation, as I was saying earlier, is considered to be a big step up, and then maybe communication should have more of a role. That's a really good point.
We have another quick question from the chat. Yeah, so do you think background assumptions about the nature of mental illness might have perhaps unconscious effects on these therapeutic encounters? For instance, if you think mental illness is just brain dysfunction, wouldn't you be less likely to take the agential stance toward users?
Yeah, so I think Matthew actually has a paper on this. I think they surveyed attitudes of mental health professionals, and you know what they thought about the kind of causes or nature of mental disorders were affected kind of the way they were thinking about their patients. I think that's definitely possible. I think it's a number of things though. So one thing that we were observing in the videos, for instance, is this: the more articulate the young person was, the better, you know, they were expressing what they were feeling, using appropriate terminology and so on, the more the practitioner ended up thinking they were actually okay, they didn't need support. So there was almost like, you know, there are a number of kind of biases that we can have. You may think that just because someone seems to be able to describe what is going on to them, then they're also able to overcome certain difficulties. So that's something that happened, especially to the kind of students, the kind of university students that we're seeing, you know, because, you know, that their people are used to kind of talk really eloquently about things in many cases. Most of their concerns were being dismissed. Another thing that we saw that we thought was an assumption and bias was, for instance, if the practitioner thought through the questioning and the answers they were getting from their questioning that the person had good social support of some sort, like had good friends or a family that was behind them, again, they were much less keen to offer any other kind of support. We saw this in particular with a case of a girl who was having problems with eating disorder. And she mentioned that she had a boyfriend. And I remember, I will never forget this. I think I say it every time, because the practitioner said something like, yes, really. I mean, when you're eating, you could just ask your boyfriend to sit there and tell you to eat. And I was like, how is that helping? You know, how is that? You know, she could not have a boyfriend. She could not want to ask her boyfriend. You might not help anyway. It's like, but this idea that because there are people that, you know, can support the person outside the clinic, then no further support should be offered. So there are a number of things I think that are operating here. Certainly, you know, our understanding of mental disorders plays a part, especially I think in the more serious kind of psychotic cases, considered serious, not that the other ones aren't serious, but the ones that are considered like more serious, but also any kind of vibe that we get from the person in the encounter, you know, how they dress, what they, you know, whether they're female or male, or, you know, whether they're articulate or not, everything kind of affects the type of support that is offered and how the person is treated, you know, whether he's treated agentially or not. An opposite case was a young man who was homeless, and it's almost like the practitioner was saying, you know, until you address your situation, there is nothing I can do for you. And in a way, you can see why the practitioner was saying that there were other problems in the person's life apart from the mental health struggle. But at the same time, you know, you wouldn't have said the same thing to someone who was not in the same situation. So I think it's a number of things that, you know, very often I think practitioners, as all of us, as teachers, as parents, as coaches, don't realize, but we're kind of really biased by certain aspects of the person's identity, and we end up not offering everything that we could offer because of that.
Great. Do we have more questions? Okay, I think we can thank our speaker for today's wonderful talk. Thank you so much, Lisa Bortolotti, for being with us today. And thank you to all of you participants for being here today. We will be happy to host you again for our next event. So October 14th, and we will have Jonathan too giving a talk with the title and abstract to be available soon. So thank you so much, everybody.
Thank you for having me, and thank you for all the great questions. Bye-bye.
Bye.
Thank you.
Bye.
Thank you, everyone. Bye.
Bye.